Basics of Renal Replacement Therapy, RRT. Renal Replacement Therapy, RRT, is essentially a lifeline for people whose kidneys have failed. When kidneys can no longer filter waste products from the blood and regulate fluid and electrolyte balance, RRT steps in to do their job. The main types are hemodialysis, HD, peritoneal dialysis, PD, and kidney transplantation, TX. 1. Structure and function of the semipermeable membrane in PD. What it is. In peritoneal dialysis, PD, the semipermeable membrane isn't an artificial filter. It's actually the peritoneum, a natural membrane that lines your abdominal cavity and covers your abdominal organs, like your intestines, stomach, liver. Structure. The peritoneum is a thin, richly vascularized, full of tiny blood vessels, membrane. It has a vast surface area. Function. It acts as a natural filter. When dialysis fluid, dialysate, is introduced into the abdominal cavity, waste products and excess fluid from the blood in the peritoneal capillaries, tiny blood vessels, move across this membrane into the dialysate. Think of it like a very fine sieve that allows small molecules, waste, and water to pass through, but keeps larger, important molecules, like blood cells and proteins, in the body. Semipermeable. This term means it allows certain substances to pass through while blocking others. 2. Structure and function of the semipermeable membrane in HD. What it is. In hemodialysis, HD, the semipermeable membrane is an artificial filter called a dialyzer, often referred to as an artificial kidney. Structure. A dialyzer contains thousands of tiny, hollow fibers made of a synthetic material, like polysulfone, cellulose acetate. Blood flows through the inside of these fibers, and dialysate flows around the outside of the fibers, in the opposite direction. Function. The walls of these hollow fibers are the semipermeable membrane. They have microscopic pores that allow waste products, like urea, creatinine, excess electrolytes, and excess water to move from the blood into the dialysate. Essential components of blood, like red blood cells and large proteins, are too big to pass through these pores and remain in the blood. Semipermeable. Similar to PD, it selectively allows certain substances to pass. 3. Types of water and solute transport in dialysis. The movement of substances across the semipermeable membrane in both HD and PD primarily involves two processes. Diffusion. Solute transport. Concept. Movement of solutes, dissolved substances, like waste products, from an area of higher concentration to an area of lower concentration across a semipermeable membrane. In dialysis, blood is full of waste products, high concentration, while the dialysate is clean, low concentration of waste products. So, waste products diffuse from the blood into the dialysate. Ultrafiltration, water transport. Concept. Movement of water, and some dissolved solutes, across a semipermeable membrane due to a pressure gradient, in HD, or an osmotic gradient, in PD. This is how excess fluid is removed. In HD, a negative pressure, suction, is applied to the dialysate side of the membrane, or a positive pressure is applied to the blood side. This pressure difference pushes excess water and some solutes out of the blood and into the dialysate. In PD, high concentrations of glucose are added to the dialysate. This creates an osmotic gradient, meaning water is pulled from the blood, where water concentration is higher, across the peritoneum into the glucose-rich dialysate, where water concentration is lower. 4. Acute and chronic vascular access in HD, complications. For hemodialysis, you need a way to get a large amount of blood out of the body, through the dialyzer, and back into the body quickly and safely. This is called vascular access. Acute vascular access, temporary. Purpose. Used for immediate, short-term dialysis, often in emergencies or while waiting for a chronic access to mature. Type. Central venous catheter, CVC. This is a plastic tube inserted into a large vein, usually in the neck, internal jugular, chest, subclavian, or groin, femoral. It has two lumens, pathways, one for blood out to the dialyzer, one for blood back to the body. Complications. Infection, most common and serious, blood clots, narrowing of the vein damage, discomfort. Chronic vascular access, long-term. Purpose. For regular, ongoing dialysis treatments. Designed to last for years. Types. Arteriovenous, AV, fistula, considered the gold standard. It's surgically created by connecting an artery directly to a vein, usually in the arm. This causes the vein to enlarge and thicken, mature, over several weeks to months, making it strong enough for repeated needle insertions. Arteriovenous AV graft, used when a fistula isn't possible. It's a synthetic tube, graft, surgically placed under the skin, connecting an artery to a vein. It can be used sooner than a fistula, weeks instead of months. Complications, for both fistula and graft. Infection, can be serious, especially with grafts. Thrombosis, clotting, leading cause of access failure. Stenosis, narrowing, can reduce blood flow. Aneurysm, fistula, ballooning of the vein wall. Steele syndrome, blood flow to the hand is stolen by the access, leading to coldness, pain, numbness in the hand. Failure to mature, fistula, the vein doesn't get big or strong enough for dialysis. 5. Description of abdominal access for PD. What it is. For peritoneal dialysis, a permanent access is needed in the abdomen to allow dialysate to enter and exit the peritoneal cavity. Type: peritoneal dialysis, PD, catheter. Procedure: a soft, flexible tube, catheter, is surgically inserted through the abdominal wall and into the peritoneal cavity. A small portion of the catheter remains outside the body, usually near the belly button, for connection to the dialysate bags. Structure: the catheter has cuffs, Dacron cuffs, that help anchor it in place and create a barrier against infection by allowing tissue to grow into them. The part inside the abdomen has multiple holes to allow for efficient fluid drainage and installation. Patient care: patients are taught how to connect and disconnect the bags, maintaining strict sterile technique to prevent infection. 6. Patient management in the planned start of RRT. How? When? This is about preparing patients for the transition to RRT before their kidneys completely fail. When to start RRT? Generally when kidney function, measured by GFR, glomerular filtration rate, falls to a very low level, typically GFR less than 15 milliliters per minute, 1.73 meters squared. More importantly, RRT is initiated when the patient develops symptoms or complications of kidney failure that cannot be managed by other means. These include severe fluid overload, edema, difficulty breathing, uncontrolled electrolyte imbalances, e.g., high potassium, uremic symptoms, nausea, vomiting, poor appetite, confusion, itching, pericarditis. Significant malnutrition related to kidney failure. How to manage the planned start. This involves a multidisciplinary approach. Patient education, crucial for informed decision-making. Explaining all RRT options, HD, PD, transplant, their pros and cons, lifestyle implications. Access placement. For HD, planning and creating a permanent vascular access, fistula or graft, well in advance, months, to allow for maturation. For PD, surgical placement of a PD catheter, usually a few weeks before starting PD to allow for healing. Nutritional counseling, adjusting diet for kidney failure and preparing for RRT dietary changes. Psychosocial support, addressing emotional and psychological aspects of chronic illness and RRT. Vaccinations, ensuring patients are up to date on vaccinations, especially for hepatitis B and influenza. Medication adjustment, reviewing and adjusting medications that are cleared by the kidneys. Choice of modality, helping the patient choose the RRT modality that best fits their lifestyle, medical condition, and preferences. 7. Composition of dialysate in HD and PD. Dialysate is a sterile solution specially formulated to mimic the natural composition of healthy blood plasma, but without the waste products. Key components, both HD and PD dialysate. Electrolytes, carefully balanced concentrations of sodium, Na+, similar to blood, helps maintain fluid balance. Potassium, K+, very low or absent to remove excess potassium from the blood. Calcium, Ca2+, to help correct bone disease and regulate calcium levels. Magnesium, Mg2+, to remove excess magnesium. Chloride, Cl, balances other electrolytes. Bicarbonate, HCO3, or lactate, precursor to bicarbonate, to correct acidosis, high acidity of blood, a common problem in kidney failure. Dextrose, glucose, in HD dialysate, present in small amounts to prevent excessive glucose removal from the blood. In PD dialysate, This is the critical osmotic agent for ultrafiltration. It's present in varying, high concentrations, e.g., 1.5%, 2.5%, 4.25%, to pull water from the patient's blood into the dialysate. Higher glucose concentrations lead to more fluid removal. No waste products. The dialysate is free of urea, creatinine, and other metabolic wastes, creating the concentration gradient for diffusion. 8. Types of hemodialysis. Types of peritoneal dialysis. Types of hemodialysis, HD. In-center hemodialysis. Description: the most common type. Patients go to a dialysis clinic 3 times a week, typically Monday, Wednesday, Friday or Tuesday, Thursday, Saturday, for sessions lasting 3 to 4 hours each. Advantages: medical staff are always present, social interaction, no equipment at home. Drawbacks: fixed schedule, travel to clinic, restricted diet, fluid intake between sessions. Home hemodialysis, HHD. Description: patients perform dialysis at home, often with the help of a partner. Can be daily or nocturnal, overnight. Advantages: flexibility, more frequent, longer treatments, can be gentler on the body, better blood pressure control, fewer dietary restrictions. Drawbacks: requires dedicated space, training, partner involvement, responsibility for equipment. Nocturnal hemodialysis. Description: done while sleeping, either in center or at home, typically 3 to 6 nights a week for 6 to 8 hours. Advantages: longer, slower treatment, gentler, less impact on daytime activities, better fluid, solute removal. Types of peritoneal dialysis, PD. Continuous ambulatory peritoneal dialysis, CAPD. Description: performed manually by the patient throughout the day. Patient fills their abdomen with dialysate, allows it to stay, for several hours, then drains it and replaces it with fresh fluid. This process is repeated 3 to 5 times a day. Ambulatory means the patient can go about their daily activities during the dwell time. Advantages: no needles, flexibility, can be done at home, work, continuous clearance. Drawbacks: requires manual exchanges, can interfere with daily life, risk of peritonitis if sterile technique is not maintained. Automated peritoneal dialysis, APD. Continuous cycler-assisted peritoneal dialysis, CCPD. Description: uses a machine called a cycler to automatically perform the exchanges overnight while the patient sleeps. The cycler fills and drains the abdomen multiple times. Advantages: allows for uninterrupted daytime activities, reduced risk of infection compared to manual exchanges, fewer connections, less caregiver burden. Drawbacks: requires a machine, need to be connected to the cycler overnight. 9. Common infectious complications in PD and HD. Infections are a major concern in RRT. Peritoneal dialysis, PD. Peritonitis. Description: infection of the peritoneal membrane, the lining of the abdomen. This is the most serious and common complication of PD. Cause: usually bacterial, often due to contamination during exchanges or exit site infection. Symptoms: abdominal pain, cloudy dialysate, most classic sign, fever, nausea, vomiting. Treatment: antibiotics, often directly in the dialysate. Severe cases may require temporary HD or catheter removal. Exit site infection, infection around where the PD catheter exits the skin. Can lead to peritonitis if not treated. Hemodialysis, HD. Vascular access infections. Description: infection of the fistula, graft, or CVC. CVCs are particularly prone to infection due to their direct connection to a central vein. Causes: bacteria entering the bloodstream through the access site, e.g., during needle insertion, poor hygiene. Symptoms: redness, swelling, pain, pus at the access site, fever, chills. Treatment: antibiotics. May require removal of the CVC or surgical revision of the access. Bacteremia, sepsis. If an access infection spreads into the bloodstream, it can cause a systemic infection, sepsis, which is life-threatening. 10. Which patients are eligible for renal transplantation? Kidney transplantation, TX, is generally considered the best treatment for most patients with end-stage renal disease, ESRD, because it offers the best quality of life and longest survival. However, not everyone is eligible. General eligibility criteria: end-stage renal disease, ESRD, confirmed, irreversible kidney failure. Overall good health. Beyond kidney disease, patients must be healthy enough to undergo a major surgery and take immunosuppressant medications for life. This means no significant active infections, cancers, or a long enough period of remission, or severe heart, lung, or liver disease that would make surgery too risky or compromise transplant survival. No active malignancy. Most transplant centers require a waiting period, e.g., 2 to 5 years, after cancer treatment to ensure no recurrence. No active infection. Must be free of active infections, e.g., tuberculosis, HIV, hepatitis B, C are manageable if well controlled, but active infection precludes transplant. No severe psychiatric illness or substance abuse. These can interfere with adherence to lifelong medication and follow-up. Adherence. Patients must demonstrate a willingness and ability to adhere to a complex medical regimen, including taking immunosuppressant drugs precisely as prescribed. Support system. A strong support system, family, friends, is very helpful. Exclusions, relative contraindications, reasons a patient might not be eligible or would need careful consideration. Active cancer that has metastasized. Untreatable severe heart disease. Severe peripheral vascular disease. Active drug or alcohol abuse. Uncontrolled psychiatric illness. Severe obesity. Often requires weight loss before transplant. Persistent non-adherence to medical therapy. 11. Technical and immunological background for renal transplantation. Technical background. Surgical procedure. The diseased kidneys are usually not removed unless there's a specific reason, e.g., severe infection, uncontrolled hypertension. The new kidney is typically placed in the lower abdomen, iliac fossa. The renal artery of the donor kidney is connected to an artery in the recipient's pelvis, usually the internal or external iliac artery. The renal vein of the donor kidney is connected to a vein in the recipient's pelvis, usually the internal or external iliac vein. The donor ureter, tube carrying urine from the kidney to the bladder, is connected directly to the recipient's bladder. Donor types. Deceased donor. Kidney comes from a recently deceased individual, organ donor. Living donor. Kidney comes from a living person, usually a relative or close friend, but can also be an altruistic stranger. Living donor transplants generally have better outcomes and shorter waiting times. Immunological background. This is the most critical and complex part, as the body's immune system naturally tries to reject anything it perceives as foreign. Antigens. Cells have specific markers on their surface called antigens. The most important ones for transplantation are human leukocyte antigens, HLAs. These are proteins on the surface of most cells in the body. They are highly variable between individuals and are key in determining how compatible a donor and recipient are. ABO blood group antigens. The A, B, and O blood types are also important. A blood type mismatch will lead to immediate, severe rejection. Tissue typing, HLA matching. Blood samples from both donor and recipient are tested to identify their specific HLA types. A closer match, more shared HLAs, reduces the risk of rejection, but a perfect match is rare, except identical twins. Cross-matching. This test checks if the recipient has pre-formed antibodies against the donor's tissues. Recipient's serum is mixed with donor lymphocytes, white blood cells. If antibodies in the recipient's serum attack the donor cells, it's a positive cross-match, meaning high risk of hyperacute rejection, and the transplant cannot proceed. Immunosuppression. Because perfect matches are rare, recipients must take lifelong immunosuppressant medications to suppress their immune system and prevent it from attacking the new kidney. These medications work by targeting different parts of the immune response. 12. Most important medications in renal transplantation. These medications are crucial for preventing rejection and ensuring the long-term success of the transplant. They are typically a combination of drugs from different classes. Induction therapy. High-dose immunosuppression given around the time of transplant to prevent early rejection. Examples: anti-thymocyte globulin, ATG, basiliximab, monoclonal antibody. Maintenance immunosuppression, lifelong. Calcineurin inhibitors, CNIs, tacrolimus and cyclosporin. These are cornerstone drugs. They block T-cell activation, which is critical for the immune response. Side effects: nephrotoxicity, can damage the new kidney over time. Hypertension, tremor, hyperglycemia, gum hyperplasia, cyclosporin, hair growth, cyclosporin. Antiproliferative agents, mycophenolate mofetil, MMF, or azathioprine. They inhibit the proliferation of immune cells, lymphocytes. Side effects: bone marrow suppression, low white blood cells, gastrointestinal upset, nausea, diarrhea. Corticosteroids, prednisone, used in varying doses. Powerful anti-inflammatory and immunosuppressive effects. Side effects: numerous and significant with long-term use. Weight gain, increased blood sugar, bone thinning, osteoporosis, high blood pressure, increased risk of infection, cataracts, mood changes. Often tapered to lowest effective dose or withdrawn over time. mTOR inhibitors, mammalian target of rapamycin, sirolimus and everolimus. These also inhibit T-cell proliferation and can be used as an alternative to CNIs or antiproliferatives. Side effects: impaired wound healing, high cholesterol, swelling, mouth sores. Other important medications: prophylactic anti-infective agents, to prevent opportunistic infections due to immunosuppression, e.g., antiviral drugs for CMV, antifungal drugs for pneumocystis. Blood pressure medications, to manage hypertension, common post-transplant. Cholesterol-lowering medications, to manage dyslipidemia. Bone health medications, to prevent bone loss. 13. Common causes of acute transplant dysfunction. Dysfunction means the kidney isn't working as well as it should. Acute means it happens suddenly or over a short period. Acute rejection. Description: the recipient's immune system recognizes the transplanted kidney as foreign and mounts an immune attack against it. Timing can occur at any time, but most commonly in the first few months. Diagnosis: often by rising creatinine levels and confirmed by a kidney biopsy. Treatment: high-dose corticosteroids, increased immunosuppression. Acute tubular necrosis, ATN. Description: damage to the kidney tubules, often due to ischemia, lack of blood flow, during the donor organ retrieval, preservation, and transplantation process. Timing: common in the immediate post-transplant period, especially with deceased donor kidneys. Symptoms: delayed graft function, kidney doesn't start working immediately, high creatinine. Treatment: supportive care, time, often dialysis until the kidney recovers. Drug toxicity, especially CNI toxicity. Description: calcineurin inhibitors, tacrolimus, cyclosporin, are nephrotoxic and can cause kidney damage, mimicking rejection. Diagnosis: monitoring drug levels and sometimes biopsy. Treatment: adjusting drug doses. Infection. Description: infections, e.g., viral infections like CMV, BK virus, can directly damage the kidney or trigger an immune response. Diagnosis: blood tests, biopsies. Treatment: antiviral, antibiotic medications. Vascular complications. Description: problems with the blood vessels connected to the new kidney, such as renal artery stenosis, narrowing of the arteries supplying the kidney, leading to reduced blood flow and hypertension. Thrombosis, blood clot in the renal artery or vein. This is a surgical emergency and can lead to graft loss. Urological complications. Description: problems with the ureter or bladder connection. Urine leak, leakage of urine from the connection site. Ureteral obstruction, blockage of the ureter, e.g., by a clot, scar tissue, or narrowing, preventing urine flow. 14. What are the advantages and drawbacks of each renal replacement method? Let's summarize the pros and cons of HD, PD, and TX. 1. Hemodialysis, HD. Advantages: done by professionals. Medical staff handle the treatment, reducing patient responsibility. Regular medical oversight. Patients are seen by a medical team regularly at the clinic. Social interaction. Patients can interact with other patients and staff. No equipment at home. No need for dedicated space or storage of supplies at home, for in-center HD. Drawbacks: fixed schedule, less flexibility, requires travel to a clinic multiple times a week. Significant time commitment. Each session is 3 to 4 hours, plus travel time. Roller coaster effect. Patients can feel very tired, nauseous, or have muscle cramps during or after sessions due to rapid fluid and solute shifts. Dietary and fluid restrictions, often more restrictive than PD or transplant. Vascular access complications, risk of infection, clotting, or narrowing of the access. Impact on daily life, difficult to hold a full-time job or travel extensively. 2. Peritoneal dialysis, PD. Advantages: greater flexibility and independence, can be done at home, at work, or even while traveling. No strict clinic schedule. Gentler on the body. More continuous clearance of waste and fluid, leading to fewer symptoms like washout or cramps. No needles. No need for vascular access punctures. Better preservation of residual kidney function often helps to maintain any remaining natural kidney function longer. Fewer dietary restrictions compared to HD, especially fluid. Drawbacks. Risk of peritonitis, infection of the abdominal lining, a serious complication. Requires patient discipline. Strict adherence to sterile technique is essential. Body image changes. Catheter site is visible. Space for supplies. Requires storage space for dialysate bags at home. Abdominal fullness, discomfort, due to fluid in the abdomen. Potential for weight gain, due to glucose absorption from dialysate. Less frequent medical oversight. Patients see their care team less often than in center HD. 3. Kidney transplantation, TX. Advantages. Best quality of life, closest to normal kidney function, often allowing for a return to a more active lifestyle. Longest survival. On average, transplant recipients live longer than patients on dialysis. Freedom from dialysis treatments. No need for daily, weekly dialysis sessions. Fewer dietary restrictions. Can eat and drink more normally. Improved energy levels and overall well-being. Drawbacks. Major surgery. Involves surgical risks, bleeding, infection, anesthesia complications. Lifelong immunosuppression. Requires taking medications every day for the rest of their life to prevent rejection. These medications have significant side effects, increased risk of infection, cancer, diabetes, high blood pressure, bone disease, etc. Risk of rejection. The body's immune system can still attack the new kidney. Strict follow-up. Frequent clinic visits and blood tests, especially in the first year. Shortage of donor organs. Long waiting lists for deceased donor kidneys. Not a cure. It's a treatment, not a cure for kidney disease. The new kidney can fail over time,